This is an arthroscopic ACL reconstruction performed by me, Dr. Brian Tan. I usually use the transportal technique for all my ACL reconstructions. That is the view of the patella you see at the top of the screen, and you can see that there is some chondral damage. This is a view of the lateral femoral condyle, and again there is a significant sized ulcer of the cartilage. And here's a peek of the torn ACL. We'll get a better look later on. But for now, we're looking at the medial femoral condyle, and on this view it looks pretty good actually. Now we pan back to the ACL, and we can see that it is torn off its origin, and it's actually laying rather flat. This is a view of the medial compartment with a view of the medial meniscus, which looks pretty good. However, when the knee is extended, we can then see that there is actually some cartilage injury to the medial femoral condyle as well. And here we have a good view of the lateral meniscus, which looks in good condition. I start by removing the flaps of the chondral ulcer. This prevents the flap from getting caught in the joint as the patient is bending and straightening her knee. I next assess the depth of the ulcer, and I decide to leave the ulcer alone, as this is not a full thickness chondral ulcer. I then turn my attention to the ACL stump. I usually try to leave a little bit of a stump, but not too much, so that it does not impinge on the roof of the femoral notch as the patient extends her knee. I next remove some tissue from the back of the knee so that I can get a clear view, so that I can decide where to place the graft. Next, I bring in a jig with a guide wire, and I then drill in the guide wire, and this guide wire will then mark the final position of the eventual graft. Here I have put in a cannulated reamer, which I will then use to create a socket for the graft to sit in. I usually make the socket 25 millimeters long, which is a nice amount of length for the graft to eventually stick inside the tunnel. Next, I pass a suture into the tunnel and out through the skin of the leg, and this suture will eventually be used to pull the graft into place. This is a great view of the socket showing optimal position. I then turn my attention to the tibia tunnel, and over here I'm using a jig to place a wire right within the substance of the ACL stump. I next use a cannulated reamer again to create a tunnel for the eventual ACL graft. I then use a debrider to clear some soft tissue from the mouth of the tunnel before eventually pulling the button with the attached graft through the tunnels and into the socket. As the button enters the socket, I watch closely to ensure that I don't pull the button too much into the muscles of the thigh. And over here I can see that the button is no longer in the tunnel, so it has been deployed. And this is a nice robust graft being pulled into place. I then check the tension of the graft to ensure that it is nice and taut. And this completes the surgery. Thank you.